The next speaker is Professor Kunii.
Thank you very much. It's quite challenging to talk after such a great speakers like Professor Takemi and Dr. Han, and also quite challenging, to keep you awake after the lunch. But I'll try. Okay, so our first slide. This is kind of declining in life expectancy due to HIV/AIDS in quite HIV prevalent countries. As you might see, actually in 1990s and the 1980s. A lot of infections like HIV/AIDS emerged or resurged, and it became kind of pandemic. And when I visited Africa, especially in the 1990s, I witnessed so many people dying every day. So even I had an appointment with, for example, minister or director general in, for example, Zambia. They excused because of funeral, because almost every week, and they have kind of 1 week leave for one funeral. So you can imagine how much kind of absenteeism, happening at the time. And kind of graveyard is growing every day. So something happened, but at the time they didn't know. For example, there was a slim disease in Uganda, and they said it's kind of people slimming down, and especially the kind of 30s or 40s people who are working very hard, kind of a labor kind of age, that they are dying every day. So they called slim disease, but actually it was HIV/AIDS. And as you know, recently they came to know that the HIV real origin of HIV was maybe 1920s in Kinshasa, spreading over around to the world. So it is quite date back to 1920s, the starting of that HIV. But anyway, they had a kind of life expectancy. Can you imagine? Life expectancy is kind of average. So 20 years decline of life expectancy means so huge, dreadful. If you see that kind of SARS or influenza pandemic, of course it is a kind of serious, but it affects just only 1 or 2 years of decline, not 10 years or 20 years. So you can imagine how the dreadful this is. And as the co-infection and also a leading cause of HIV, tuberculosis also the research. And in many countries, especially the high prevalence of HIV countries, also increasing these case infections. That is why the global leaders, especially G8 group, gathered at the time in Kyushu Okinawa summit. At the time they took up the agenda, health agenda, the first ever. Usually, as the kind of military things, conflict, and economics is the first. But they never taken up the health agenda. But this is first time taken up HIV, and they discussed very seriously and agreed on real action is needed. Okay, that is why 2002, 2 years later, the Global Fund was established. So they expected a lot to Global Fund, not just the one international agencies added, but they really expected Global Fund to take action and really curb the epidemics. That is why Global Fund's task was so serious. People put the money, but money, okay, money is important, but money itself couldn't really curb that kind of dreadful infections. So they needed something new, very innovative. But anyway, the money accumulated, the disbursement is 31 billion. And finally, since 2002 up to 2016, around 14 years, we could save 22 million lives saved. It is kind of attribution. And TB itself, 5 billion we dispersed, and 15 million people detected and treated. Unfortunately, TB allocation is just only around 18% out of 31 billion. First one is 50% for HIV, because so many demand, especially for people living in HIV, because so many people dying every day, so they had to provide ART, the antiretroviral drugs. In the past, it was very expensive, you imagine 20 million US dollar, 20,000 US dollar per person per year, right? It was very expensive. Even now in Japan, they cost a lot. You know, it's around 15,000 US dollars still here. But because of the market dynamics, our negotiation, etc., it reduced up to around 70 US dollar per year per person. So it's a quite dramatic one. But anyway, at that time, 2002 to 2003, we didn't imagine we could scale up this ART to, you know, the world in Africa. But anyway, it was very costly. That is why 50% of our funding are used for HIV. And malaria was also expensive because of a huge amount of LLIN, the long-lasting bed net, should be distributed. So it's around 30%. And tuberculosis, especially, it is quite not so much costly. Of course, MDR-TB very costly, but it was not so much unit cost. So 5 billion could save around 15 million people. And you can see Global Fund, this is trend in donor funding. Actually, there's not so many agencies supporting tuberculosis. It is true. Actually, HIV field, top one is not Global Fund. Top one is PEPFAR, the present, you know, the emergency one. So it is the US provide a lot of huge amount of money through bilateral one to HIV. Malaria also quite good. There is a present malaria initiative, also provide a lot of money. But tuberculosis, actually not so many, you know, donors. So Global Fund now the share around 75% of international assistance. So many countries really rely on Global Fund. But Global Fund is not implementing agency. We don't call Global Fund is doing this. We call Global Fund is partnership organization. We made the mechanisms, okay, make an action. Because as I said, money talks but not walk, and not really kind of put a real action. So we need to use money for partnership. So we invite WHO for norm setting, World Bank for other funding, and other many implementers to support on the ground. So Global Fund is kind of mechanisms, right? So we usually call shared responsibility and collective efforts. So through this, we could reduce TB mortality around 44% since 2000 and save 38 million lives in 15 years, and deaths declined 31% in these eligible countries. However, you know this very famous graph. We now set a target, 2030 or 35. 2030 is SDG goal. By the 2030, we try to end epidemics. But end epidemics is not elimination or eradication, right? End epidemics as public health threat, okay? So it means if we can, control and control such kind of pathogens in a very low, even there are some cases, we can control very easily. So we no need to spend a lot of money and not so much kind of fear, right? So by 2030, we try to reduce. And this NTB strategy, we have a common global goal and target. And by that, 2035, we try to reduce the incidence by 90% and deaths 95%. But if we do just business as usual, it means 1.5% or 2% reduction of incidence every year. We need another 500 or 150 years, more than that, right? So we expect just only 2180 we could reach. So it's far away, long way. So we have to curve, bend the curve, right? So bending the curve, this strategy try to, increase this reduction rate up to 4% and 10% and around 20% by optimizing current tools, even current tool, even without new innovation. If we optimize, not just use, but maximize and optimize current tools and pursue universal health coverage, we could maybe bend the curve like this, and we expect new vaccines or new prophylaxis or better kind of diagnostics and medicines we could reduce, and by 2030, 90% of incidence deaths. Can you imagine it is possible or not? We should, okay? But of course, challenge is very huge gap between real instance and case notification. Global Fund is supporting the prevalence survey in many countries, and we found real prevalence is much higher than we expected or we estimated, right? Sometimes 2 times or 3 times. Could you imagine? Every day we surprised. Wow, this prevalence survey told us 2 times higher than we estimated. So we are now, correcting, and we really need kind of an innovative action, right? So how to just, solve this underreporting or underdiagnosis and narrow down this gap. And 10 countries account for 77% of these missing cases, okay? 4 million missing cases. And 3 countries account for 50%, namely India, Indonesia, Nigeria. You can see India here, Pakistan, Bangladesh, China, Indonesia, many countries in Asia. And of course, MDR-TB, big program. And especially MDR-TB, even here, Philippines here, right? India, China, Russian Federation, 3 countries account for 45%. And difficult thing is success rate is very low, and sometimes unit cost is very high. Could you imagine some of the countries, especially Eastern Europe, they hospitalize these cases more than 200 days and spend sometimes more than $50,000 per person. Can you imagine in US, $500,000 for one MDR patient? But now there is a huge gap, even unit cost. So our role is also market shaping and also program quality. Just improving quality and try to reduce unnecessary, treatment. So putting the shorter regimen, as you know, the MDR-TB has a now shorter regimen, and better, the treatment is very, very necessary. So it is not just only scaling up this, intervention, but also quality improvement. Okay, so Global Fund, now we have a 10.3 billion. Thanks to all the donors, we succeeded the replenishment last year. The Prime Minister Trudeau in Canada supported this replenishment. And Obama also placed a huge amount of money. Actually, now it's a bit kind of difficulty. Fortunately, maybe first year of this pledge would be okay. Recently, how many days? 5 days ago, we discussed, because we have so many, some of the stuff coming from White House. So they have a lot of kind of communication with the White House. And fortunately, the first year of a pledge would be maybe saved from US. But the USAID cut around 30%, and a lot of kind of, the influencing negatively. And maybe we have to cover some of the, missing cases. So anyway, we have now 10.3 billion for country grants, but we have some catalytic funding, and around 80%. This is kind of just indicative, because country can decide this allocation. So if they feel more, TB money is needed, maybe they can negotiate with, other communities, and they can increase. Okay, so it is indicative. But anyway, we trying to allocate. We already allocated money to many countries. This is high impact Asia, high impact Africa, 1, 2. These are groups of the countries, and we provided over 70% of allocation of TB or these to these countries. So in the past, we were quite reactive. We just waited for some application from countries. But nowadays, since 3 years back, we become very proactive. We have country dialogue, and we upfront allocate money to the countries based on ability to pay and also disease burden. So more disease burden and the lower ability to pay, we provide more money. so that now it's a good allocation. But at the same time, we try to provide technical assistance or some other support to the countries to make a better planning and also implementation. Okay, so these are the top 10 countries of allocation for TB. So India, Pakistan, Indonesia, Bangladesh, Myanmar, Philippines is here. Hi, yeah. So and the DRC, Ethiopia, Ukraine. Okay. And now, in the past, we had a quite rigid mechanisms, kind of one-size-fits-all application, review, yes and no, such kind of very one-size-fits-all. But nowadays, we are supporting more than 100 countries. So we try to be more flexible and country-specific and country-centric. So we are using now development continuum because this is a life expectancy, or we can show also a disease burden or something, and this is an income per capita per person. So the countries over 100, are quite different stages. Some are very low capacity, low ability to pay. Some are big burden, but also, better ability to pay. So we just categorize some of the, the groups, and we try to make a tailor-made approach, we are calling. So, for example, challenging operating environment like Somalia, where I worked, and Myanmar nowadays, getting better. But those countries who have a very low capacity, and sometimes a low number of implement partners, we have to do some other kind of way from intervention in countries in transition or middle-income countries. These are the countries who can graduate from Global Fund, so we support for transition, okay? And we have now the new strategy, 6-year strategy from this year, and we have a build resilient and sustainable system for health. This is really supporting UHC and SDGs. Because without health system, we cannot really control this disease, right? That's why we try to strengthen. But if we call health system, it is so broad. Everything in health system. If you see that the definition of a health system of WHO, it's everything, right? So sometimes very difficult. That is why we focus, especially because community response system, this is kind of a primary area we really need to strengthen, right? Because this is a place, community is a place, people are living and suffering, and sometimes no resources for health access, right? So we just try to support this one. And reproductive, maternal, neonatal, child, nowadays adolescent health, and platform for integrated service delivery. Because sometimes, efficacy is not, efficiency is not so good if you give a vertical one. That's why Professor Takemi's T-shape approach is very critical. Okay, vertical approach is important, but how to bind those and how to integrate to increase efficiency and effectiveness. Okay, this is very critical. So we just try to support the platform and procurement the supply chain system. This is actually number one for us because over 40% of our budget are medicines, diagnostics, etc. So this procurement supply chain is very, very critical. Human resource, of course, very critical, but human resource also everything, right? So we also focus on community health workers or primary health care givers. Data system capacities, these are very, very critical, but not just only for data generation, but data use, okay? Analysis and use. And we also build capacity. Sometimes or many times, the agencies, get the money, get the data, and they use for themselves, but never, give a feedback. So we really need to, the focus on more feedback to the community people who, generate and use. Because if ownership of data comes to the, those primary health people, they work very hard for, the data as well. Because when I worked in Myanmar, I worked in Myanmar for 3 years during that military regime. At the time, they didn't have any ownership. So sometimes they call that the coffee shop data system because they don't, seriously take the note, but they just go once a month, they go to coffee shop and they put the data. It means, the useless data, they report it, right? So we really need to use that. And national health strategy. Okay, now we try to avoid a duplication of planning. So we don't need any plan or application for global fund for the sake of global fund. We support country to make their own plan for national TB programs. It is a kind of a strategy. And they use that strategy for global fund. No need to duplicate. But before that, this national strategic plan should be very sound, right? Sometimes not sound one, just writing, but not good sequencing, not good planning, or no budgeting, not good budgeting. That is why we also need to support to improve these health strategies with good budgeting, sometimes good allocative efficiency, etc. And the financial management, of course, very critical. And okay, as I said, planning. The target setting is also very critical, right? So we sometimes support with academia, supporting the country's planning using some modeling and the better target setting and better allocative efficiency engagement. And we also have a strategic partnership. As I said, we are a partnership organization, but not just only partnership for the sake of partnership. We need to be very strategic. So with WHO, we have agreement and thus expect WHO to set the norm and give the good guideline, and so quick pre-qualification. Sometimes it is very slow, so we just push them to make a better pre-qualification. UNICEF, we work especially the community level, supporting the integrated community case management. Nowadays, child TB. Actually, UNICEF was not working for child pediatric TB, but nowadays they have an expert and we are working together. And the World Bank, of course, the health economics and the health financing. OECD, we're working, making a network of health financing officials to support domestic financing and also putting more resources to health. And academia, modeling and the data system, and the civil society is, of course, implementing partners. And catalytic funding, we have 800 million for catalytic funding to be catalytic and increasing that the financing or implementing partners for gender, human rights, K-pops, and insecticide resistance. It is a bit slow in the proliferation and others, so we just try to stimulate the market dynamics and supply chain as well, and others. And especially gender, human rights, they talk a lot about gender and human rights, but not good programming. So we try to make a better programming, really kind of influencing on the ground. Okay, this is one of the examples, Philippine case. Yeah, we use that kind of a modeling, and we worked with the Australian modeling network, and supporting the DOH, the Department of the Health in Philippines. This is our incremental cost. It is kind of using that model. We check that the variety of interventions, and check that how much incremental cost is needed, and also how much the active TB cases would be avoided. So more active case avoided, but the lower incremental cost is better efficiency. Okay, so if you look at this, so these are quite better, and also cost efficient, effective intervention. So engagement of providers not compliant to national TB program protocol plus preventive therapy in children. Okay, and this engagement of providers not compliant to NTCP protocol and preventive therapy in children, systematic screening in people living with HIV and diabetes. So this is kind of selective one, but the lower one, not so much incremental cost or higher incremental cost, but the lower about it, people about it are systematic screening in rural poor, preventive therapy for adult. We don't say these do not necessary, but these are maybe necessary, but not so much cost effective. So if you have a very limited, resources, maybe better to use first or sequence, or more resources to be here. It's a kind of no need to be very much kind of following that one, but it could be used for negotiation discussion, right? Because there is no perfect model, so it could be used for kind of discussion. Okay, although we support global fund support and domestic financing there, still there are funding gap. Actually, currently we have a 2 billion US dollars identified as a financial gap. So we really need to fill this gap. And of course, out-of-pocket spending is so high, sometimes over 50%, these areas. That is why we really need to increase domestic financing or innovative one. So we are now supporting that the sustainability transition and co-financing, especially countries in transition, how they can be self-dependent and also sustainable for programs. And when we call sustainability, it is not only financial one, but also programmatic and governance. Governance means not only government, but also civil societies to be participating in planning and implementation. These are very critical because some of the countries, they are neglected. Civil societies have no voice, and especially vulnerable populations. So global funds, maybe innovative way, is a coordination body in each countries, inviting UN agencies, international organizations, and also civil societies, even people living with such diseases, and also private sectors. So this kind of governance maybe need to continue. And national health accounts, capacity building, institutionalization is very critical. And we need to provide incentives for co-financing, increasing co-financing, innovative financing. For example, debt for health or social impact bond, matching fund. Actually, there are a lot of kind of things. Of course, not so easy, but we are seeking this one. And even we are talking with World Bank for loan buy down. And as I said, senior budget officials we also building network. Okay, this is final slide. What I expect and what is the take? So to Professor Takemi, I want to ask, because he's a real kind of champion. You know, the Professor Takemi is a very rare politician. Not in front of him I am talking, but he's a really kind of champion, right? He's a rare person. And he's really kind of, doing this global health agenda as a center of this diplomacy. And also he is supporting not only Global Fund, but other one. So please keep this financing to international, the donor funding. Especially the Japanese contribution, very important, but still 0.4% of the GNP. So maybe they call that 0.7%, that maybe double or triple would be needed. I don't say, but even kind of share to the health is also very quite low. Only 2% of the ODA is allocated to health and the population. So maybe if you put a kind of a 7% or 6%, it will be a triple. So I hope Professor Kim to continue to the advocate. Okay, Dr. Tan, the increased domestic and innovative financing. Of course, she is already pushing, but this is very critical. Not just only money, but maybe you can persuade the financing ministry and even at the provincial level. You really need to kind of sensitize those kind of people, how important and how this investment in health really kind of give so much return, right? And of course, the lot of measures we need to reduce the catastrophic health expenditure. And human rights, social protection for vulnerable populations, especially in these TD cases. The prisoners, migrants, there are so many vulnerable populations who we don't see or their voices not reaching, right? So these are the people really, need to be taken care by politicians who have voices. So our, kind of this SDG slogan is no one should be left behind. So we really need to make this realized. Thank you very much.
Thank you very much for your valuable remarks from the viewpoint of multilateral donor institution regarding expectations for donor countries and recipient countries to aim for the early eradication of abroading. So now before we move to discussion, please go ahead with